Well, hi, my name's Jay Lucas. I'm a board-certified plastic surgeon. I've been in practice for 23 years, 22 of them here in Knoxville. I do enjoy post-bariatric body contouring. It's been a good portion of our practice for ever since I got started. You know, a little bit of my background, because I'm getting old. I started medical school in '87 and did my general surgery training in the '90s, late '90s, plastic surgery, and then a fellowship finished in 2001. When I was going through general surgery, bariatric surgery was very much at infancy, and honestly, it was pretty morbid because it was all open procedures. There wasn't like nice support systems like here at that time, and so really it was a tough operation for people to undergo, and as a result, there weren't many. So I never saw in my training, I was at a busy training program, any post-bariatric massive weight loss patients. They weren't there. So when I got started, I started seeing, that this was coming through our door. Now, granted, it's not like it's so brand new or different, but the techniques for someone who has lost 100, 150, 200 pounds, that tissue is so much different than, say, somebody that had just gained a little bit of weight with pregnancy and so forth. So I had to bury myself into a lot of training experiences in conferences and so forth. So I sort of self-taught myself in addition to mentorship along the way. And, I really enjoyed it because it's a lot of design, because no two individuals are the same in how they gain and lose weight. So it makes it interesting, and they're big surgeries. They're generally, a lot of them are anywhere from 6.5 to 8 hours long. So particularly as a young surgeon, I was like, yeah, this is great. But, over the years, I have noticed that it's not just the surgery component. What I found a lot of for people who have had weight problems all their life is that not only are they interested in having body contouring, but also getting some healing. I think what a lot of people struggle with is there's that kind of that soundtrack in the back of your mind as you all your life, and you hear nothing but negative thoughts. You hear that you're not good enough, you're not worthy, you don't look like the person that is the social media influencer of the month, or someone you see on TV. And what I firmly believe that all of you, all people are created in the glorious image of God, and you all have a purpose in life. And what I want you to do is change that narrative, that playlist in your head. Instead of saying, I'm not worthy, I'm not good enough, I'm not able to receive love, I want you to have that positive affirmation, like, I am somebody, I am here on earth for a purpose. And so that's something that our office tries to instill upon, because we also know that coming to a plastic surgeon's office is an intimidating thing. You coming in, you're meeting a total stranger, you're getting naked, showing all your areas that you're concerned about and feel insecure. And so we get that, and what we want is to make you feel at peace with yourself, and to know that you're more than just your weight loss number. So but getting off the soapbox, bariatric surgery, as I said, we generally want to wait about 15 to 18 months to allow your body to equilibrate. And as I mentioned, everyone's got different goals and different concerns, and everyone loses weight differently. But, in general, we do know that people who undergo bariatric, post-bariatric body contouring are way more likely to maintain your weight than, say, someone who never does, because even though you've lost weight and you've lost those risk factors from diabetes and hypertension and all that, if you're a prisoner of your own soft tissues, then you're not realizing kind of all the accomplishments that you've done. So if you get a lot of that weight off, then you start to be more protective of your assets, if you would. You have some skin in the game. So it is an important step that a lot of you probably should consider entertaining, because it will help you be more conditioned to try to keep yourself where you need to be. And just to keep it in mind, insurance companies don't. I mean, they may say they cover it, but they don't provide any reimbursement for the complex things that we do. So insurance just isn't on the table at all. So you just got to take in that account. So in general, yes, there are people who say, I really want my arms done first, or I really want face, or I really want this or that. But in general, most people, the central lower torso is sort of that keystone area that we want to first establish. So it generally involves an abdominal procedure. And what the narrative is where is your excess? And the big thing is it more of a vertical dimension problem? Is it a horizontal problem? Or if you've lost a whole bunch of weight and you kind of have a circumferential laxity all the way around, then a lot of times we're addressing that as a circumferential lower body lift. So it really boils down to what your goals are, what areas you're concerned with. And then the other thing I always just want to start out is, it's very seductive to say, I got this wish list. I want to do the mommy makeover. I want to do breast and belly and legs and all that. You can't do that all at once. It's too big a surgery. Yes, there are some universities and some groups where you have a partnership. You got two big guys banging it out, and they have assistants and all this. But the bottom line is, no one needs to be under anesthesia more than about 8 hours. It's just not smart. And so in general, you're going to be in a staged approach, because, for me, most belly operations, and I'm not talking about circumferential, they're 4.5 to 5.5 to 6 hours. Most breast rejuvenation, because they're not normal after bariatric. Your soft tissues are loose and elastic. They can't hold breast implants easily. And so you're looking at 4.5, 5.5 hour operations. So you can't do both together. It's too much operating. And so just kind of get that in the mindset. These are complex problems that need a long time to address all of them. So, like I said, you might find places that will do it, but, just because you can do it doesn't mean it's the smartest thing to do. So, kind of, if somebody says, I'm interested in my belly, to me, the algorithm is, okay, are we looking at a vertical excess? Are we looking at a horizontal excess and vertical? So those are two different kind of operations. The traditional abdominoplasty, which is addressing really abdominal wall laxity, it addresses some fat equilibration, it addresses the vertical removal of skin. That can take care of a fair number of people. But if you have, like on that previous person, where there's a lot of horizontal excess, just pulling things down inferiorly will not redrape that appropriately, and you'll have a lot of loose, lax skin. So that's where a technique known as the Bldg pattern, and I'll show you that, but it's kind of like, the French Bldg, and you know, that is where that has benefit. Sometimes even doing that as a staged approach where you do a traditional abdominoplasty and come back and add the vertical component next. But as you see, there's all different flavors and shapes and sizes of individuals because we're all unique. And each one of these are addressed in a very different manner. So this was a lady that actually had one of the more aggressive bariatric procedures, the pancreatic diversion duodenal switch. These people, if you're one of them, you got to understand your nutritional status is quite compromised. You're anemic, you don't have enough synthetic function of your liver in many cases, and you got to be optimized. This woman came to me, I mean, she had lost a tremendous amount of weight. She'd lost a little bit too much, and she was even on like an Ozempic agent. We had to get her off of that for a little while. Actually let her gain a little bit back. But you know what we have to watch out for before we operate on a case like this is if you're iron deficient, you can take as much iron pills as you want. You're not building it up again because a lot of times you can't absorb. So a lot of times we have people go through an iron infusion once a week for 4 weeks to get you ready to have surgery. Because if you're, you know, the building blocks of healing is iron, vitamin C, and protein. And if you're lacking any of those components, you're not going to heal right. You're going to get wounds opening up. So, you know, those are important things. So this was her abdominoplasty. As you can see that, you know, from the side, this convex kind of shaped abdomen is related to muscle wall separation, causing your abdominal wall to fall forward. And then mostly she had a vertical excess, a little bit of pubic excess contour that needed to be addressed at the same time. But, you know, that's an abdominoplasty. Get rid of the hooding effect. We repair the abdominal wall and kind of restore the anatomy. And you can see the difference between that scaphoid bulging abdomen. Now it's flat because of the abdominal wall muscles are repaired. An abdominoplasty is not a simple operation to endure. It's quite uncomfortable with the abdominal wall repair. And it's in general, it's a 6-week recovery, but it takes about 2 weeks to kind of get over the hump. And once 2 weeks is over, you're feeling pretty reasonable. But it is not like going and getting your hair done. It's a real operation. There's another lady that she did not lose weight. She was she lost a minimal amount, so she still had quite a bit of excess adipose tissue, fatty tissue. Had some vertical skin excess, abdominal wall laxity. She'd never had children, however, and this was an abdominoplasty. Not everyone scars perfectly. It's a little bit wider scar than some, but you know, I can do the same technique on 30 people and get 30 different scars. So that's something to keep in mind. But in general, we try to keep more of a vertical, narrow belly button and not a bullseye look. And then we also addressed her back at the same time. We did some fat lipoequilibration, which you can see that kind of really smoothed that area out. But that's a whole different one. This was a lady who really had not lost a lot of weight, except for just peri having children. And yes, this was a case where we did do the breast lift dog and abdominoplasty at the same time because nothing was that complicated. Duration of surgery was about 8 hours, but she was young and healthy and could endure that. But you can see the restoring the normal anatomic anatomy of the abdominal wall and how that changes, and then addressing the perineum, particularly with Lululemon being the fashion craze. Now this was a woman who, well, you know, we already showed this one. This is an example of a fleur-de-lis pattern where we're removing tissue along a vertical axis, tightening horizontally, and then a horizontal axis tightening vertically. And it allows us to get a tighter look, because if all we had done was this, This would all be real lax.
Is the vertical incision right above the navel, or how far up does it?
It goes almost to the décolleté. I have to be careful about that, because the greater the tightening is right about here, the more and more a dog ear will be created. So you have to temper it. Whereas, yes, I could tighten more here, but that means, you know, it's basically whatever X is here, it's 2X on each side to account so that it's a flat line. And so that is something that I had to be cautious of, that you're not running it up too high and then you look like you've had a sternotomy. But this fleur-de-lis is very helpful, and quite frankly, some people say, you know, I'd rather just do the abdominoplasty, and then we can come back and add the vertical component later, and it allows people to see, oh yeah, I got this lax skin, and if it really didn't bother them, then it's a whole lot less operating and less scar burden. But this is essentially showing you the dimensions and the vector of skin reduction and design that we do, but it can make a real difference. And you can see we give her a much tighter look. So you know, the circumferential body lift, I still do a fair number of these every year. They're big ones. I don't just jump on everybody to do it, but you know, when you start getting in the 90 to 100 pound weight loss range, you've got a circumferential problem. You got laxity here, you got lateral thigh laxities, you got a lot of other things. So this allows, I mean, essentially, you could call the lower body lift a culmination of an abdominoplasty, a monsplasty, a flankplasty, gluteal kind of repositioning, and lateral thigh, if I didn't mention it. So it's a big operation. It's a lot of components all thrown together into one. Now, if somebody only really cared about the anterior abdomen and they don't care what's back here, I'll leave that alone, you know. But once again, these are questions that can be inquired upon and addressed at the consultation, so that we're customizing it to what you need. Just because I may see that, if you're not, I certainly don't want to push more surgery on you. So, but it is a very powerful technique, but it's a big operation. It's 7.5 to 8 hours in most cases. But it's all day surgery. You go home, because hospitals will kill you, because they don't understand plastic surgery, because plastic surgeons haven't admitted anybody in years. And so the nurses don't understand the number one most important thing is you got to get up and move. And if you don't, you get blood clots. So we don't admit anyone, and people do fine, even with these big operations. So this is kind of an example of somebody that had a lot of deformity. We always mark you the day before. I spend about 30 minutes to 45 minutes marking, because if I spend that much time, and the marking part is where all the design and principles of tension and everything else come into play. So I'm tired after I mark. I don't want to jump into another 8-hour operation. So I always have you mark the day before. And so, yeah, all this hieroglyphics, but this lipo contouring, and we undermine all the way down the thigh that low and then pull everything up. These green hashes is where we recycle the tissue, don't throw it away, and kind of turn it down onto the gluteal area so that when you pull it up, it won't be quite as flat. But, you know, and that kind of going all the way around. So that's her. She had some little bit of tension stuff and a little bit of spitting sutures, but you can see that it can do a lot to improve the contour. That's her from the back. Now, this kind of stuff is addressed as another operation where I kind of refer to it as more of an upper body lift, where it's a combination of the arms, brachioplasty, and then a lateral thoracotomy, thoracoplasty, where you tighten things. So, as I said, they're staging. I mean, I couldn't have done any more than that anyway. This was actually the first circumferential body lift that I did in '04, And at that time, I was not concentrating on mons pubis and the importance of kind of sleeking that up. So there were a lot of things that, I learned from that first one. But it was kind of the similar marking patterns that haven't really changed a whole lot. Another one that had a circumferential body lift, and her pattern. And sometimes, not very often, I need to add a vertical wedge to remove from the mons pubis to make it a little sleeker and not so wide. But in general, you can fat equilibrate and superiorly reposition, and it generally takes care of it. And that's another person where I learned that hair-bearing skin doesn't heal as quickly as others. So now I use an external stitch that is pulled out at 2 weeks and does a much better job than the quick dissolving buried sutures. And all scars look horrible early on because they're pink and nodular and with massage, and it takes about a year, and that calms down. I also show this because this person had a little wound complication on her flank. So it happens, not very often, but when it does, you got to understand there's some wound care that's going to happen. So just let people see that it can occur. So yeah, another example of technology in me. But and then see that this person, I did an external stitch, and you see how it healed a lot better, much narrower line. But similar thing, the mons repositioning, as well as the lateral thighplasty of the abdominal wall, tightening, skin removal. So you can see that it can make a nice difference. So I think that's another circumferential that was quite a few years ago. But you see, making a nice difference. Do them on guys too. Now he had this guy, I've known him for a lot of years. He had one of those lap bands. I don't know if you ever heard anything about them. Most people could cheat through them very easily. It's essentially a blow-up little portal that kind of compresses the outer abdomen or outer stomach. And so we did a circumferential, and we actually moved his portal, which was sitting right here. It almost felt like a little button. And we moved it into a new place. And I made a nice difference for him. And you can see, you don't see that anymore. We were able to put it in a more defined place. So, I don't do paniculectomies. I did do this one because she had MS. She was weak. She had trouble transferring, so we did a paniculectomy. As you can see, and even then, that was a paniculectomy where I still can't quit being a plastic surgeon. I'm not going to do it like a general surgeon, and I'm at least putting the belly button where it needs to be. But it's an awful operation. I don't recommend doing it. So anyway, those are people we converted into a circumferential. But like I said, you'll hear all the time, "Oh yeah, you need to go do the mommy makeover, breast and abdomen." Yes, you can do them together, but you got to have the right kind of person. You have the right tissues, something that we can get done in a reasonable 8 hours. Not more than that. And most bariatric cases just take longer. It's a little more involved. Tissue quality is just different. This was a woman who had saline breast implants that had bottomed out. Someone had done an abdominoplasty. This is an example of not treating the circumferential part when you really needed it. And so we had to do a sort of a hybrid extension because she had this scar that went way up here anyway, and we were able to reduce that. That's a much higher scar than what I would normally do. This also shows kind of that lateral thoracoplasty where we extend it down, but we can get rid of that redundancy through there. We extended it from the arms, and we had done a breast lift augmentation. See how it can change the hour, because essentially it's kind of like a lampshade with the weight loss deformity where things hang off of the lower ribs and then descend down. And so you have a narrower amount here and a wider amount here. And in order to get rid of that, you're still going to have redundancy of tissue of the upper incision line. And that's why you need that lateral thoracoplasty to be able to tighten that up, or else you're just not going to have it. So there are a lot of vectors of pull that you just have to do that you wouldn't otherwise, depending on the tissue. So what's the difference between a bariatric breast and a normal breast? The ligamentous support of the breast, for one, is diminished. The folds are weak, and that's the natural floor that an implant would sit. If I can help it, if you got enough tissue to work with, I try not to use implants on breast, on post-bariatrics, because, like I said, you're in a point where tissues are lax and they're more likely to fall. A lot of times you got to employ the use of these surgical scaffoldings, and believe me, they are way more expensive than the implant. So they're not inexpensive. So if I can avoid making you go down that road, I will. If you've got nothing to use and you got a lot of skin, then that's something that we have to deal with. But it would involve almost like an internal hammock of a slow dissolving material that also helps support the device. And then you have to address the skin envelope excess as well. So there are a lot of factors that come into play. And like I said, that kind of breast is not a one-stage breast. That's a lift first and then come back and put the implant in, or else those nipples will die. So you got to do them in a couple stages. So, it's just kind of showing where you're weak is right through here, and that's going to make these fall. So you've got to be careful. Those are kind of examples of, originally we used a lot of acellular dermal matrix grafts, and those are like human-derived tissue, and it's what's used a lot in breast cancer reconstruction. The problem is they're really expensive. Now they have a synthetic biosynthesized material that has pretty reasonable characteristics, and it used to be fairly inexpensive to work with, but now the breast cancer surgeons are starting to use it because it cuts down on their facility fees and everything, so the hospital doesn't get as mad. And now that company is like, okay, we got all the insurance stuff that we can charge 3 times as much. So now I was blown away how much more. I had to quote that on somebody, and I got a price back. I was blown away by how much it had increased in price recently. But like, this was a woman that came to me, bottomed out, expanded folded nipple, which means that the implant, which originally sat up, is starting to fall lower and lower and lower, and it goes into the armpits. It's not a nice thing to have happen to you. So and this person had this bottomed out, no projection, and we were able to add some additional support to try to keep them where they need to be. But they are challenging cases, and then that's one generation of this biosynthetic material that you can put in, so that it's under the muscle on one part, and then you're adding support here and anchoring it to the fold, and you're able to have it be much more stable than a free-floating implant that someone else could handle pretty well. And this was a woman who had implants before and then had weight loss, and the implants fell. You can see all that redundant laxity. She was one that we did a circumferential on and then came back and added the Bldg component. And you can see how that tightened up that epigastrum, and really gave her some anchorage there versus there. This was a non-bariatric patient, but she was one that had implants that just bottomed out. So all her breast is sitting on her belly, no implant sitting where it's supposed to be. We downsized the implant. We actually did this whole extracapsular adjustment. I was able to do it without the synthetic material by downsizing and doing a lot of reshaping. But at the same time, even though this is pretty stretched out, it's not quite like a bariatric breast, and we're able to bring her into some more normalcy of shape and position. So that's some of the markings you would see with a mastopexy. Some more examples of mastopexy OGs, but once again, those are non-weight loss, because then their tissues are just better and they look better as well. But this is a technique that I try to employ for people who still have a reasonable amount of breast tissue, and we're not using an implant, we're giving them shape, and we're not overloading the skin because it's their own tissue. And what we also do is we take some of this tissue that is hanging on the belly and we actually deepithelialize it like a little flap, and we flip it up underneath the muscle, so it's sort of an auto enhancer of that upper pole. So you get a little more upper fullness than you would have otherwise with a normal lift technique. This was a lady, she had very big breast. She had plenty to work with. We were able to reshape it and, give her some reasonable upper pole fullness. This is where we go in and do this, what I call an axilloplasty or a thoracoplasty, where we're getting rid of that lateral bra roll. Makes it nice to another example of that as well, where I didn't put an implant in, but it gave her pretty good shape and not overloading the soft tissues. But this is a whole different animal than, say, someone like that, and you have to deal with that differently. And like I said, the only way to get rid of that kind of redundancy is lateral chest wall plasties on each side, and extensive skin removal, which I often now have to go all the way to the wrist and in terms of removal for someone who has that much tissue loss. In most cases, we can stop at the elbow so you don't see it. But that's a classic marking pattern of when we do the brachioplasty or the upper arm lift and the lateral chest wall lift. And that helps us get rid of that redundancy that is here. And there's a little zigzag because anytime you put a straight line closure over a joint space, it's going to really pull and lead to a wide scar or a tethered scar. So we do a little Z-plasty, which adds vertical length. And you can see, so this is a pretty popular procedure because a lot of women that have lost a lot of weight feel very uncomfortable wearing sleeveless shirts, and this time of year it's nice to wear that. The nice thing about the placement of this scar, although when you are doing this, yes, you see it, but when your arms are down, you're not going to see that scar too much from the frontal or the back view, and it's not that often you're doing this unless you're a airline stewardess. But you can see I can get rid of this, and that lateral thoracoplasty is real helpful to get rid of those bulges above and below the bra line. So now, I'll keep this up there because, sometimes you have a little redundancy, and we can do little touch-ups of that later on in the office, and that can be done under some local numbing medicine pretty easily. But, sometimes soft tissues just don't redrape quite as nicely. The brachioplasty, or that upper arm lift, probably has the widest bell curve of the width of the scar because it's all related to the dermis that you are sewing. And if the dermis is sturdy enough to hold suture, you can get a pretty good scar. If that dermis is kind of thin and wispy, that may not hold as well, and you're going to end up having a wider scar. But that's, another example of that, and that's common scar pattern. That other one we'd shown you before. And like I said, this woman had a lot of operating. She was always wanting more and more, but you can see we were able to get her arm quite a bit tighter than that, able to give her a lift, and we had both the horizontal resection as well as a vertical resection to really get her in a tighter manner because she was a avid suntan person for her tanning bed. So her elasticity is even more compromised. And this was a woman that she was that first body lift I did, and then she was the first one we had done a brachioplasty on and a breast lift, and we did some things to change that later on. I don't have many guys in here, but gynecomastia or male breast is something that is commonly requested. We do a lot of gynecomastia work. For someone like this who hadn't had a weight loss, their elasticity of their skin's pretty good, we can do a minimally invasive technique where it's a combination of lipocontouring, releasing all the tissue, and then going through the nipple itself and resecting all the glandular element out. And it's pretty much scarless operation, except for one poke hole for the lipo here, but in the nipple itself, no one really sees that. But most, this was a guy that hadn't had bariatric surgery, but was quite a bit overweight. We were able to get it a little better because he didn't want to have scars, and I didn't disagree with him on that because he was a young kid. This guy, we did the full, it's essentially a mastectomy, but we then do a free nipple graft and put it in a reasonable position. And the scar does go all the way out, but when you have all this loose redundant tissue, you don't really have a choice. But that essentially can get rid of a lot of the excess there. Another operation that rarely is used, but it's a nice way that if people have already had an abdominoplasty, they still have redundancy up here, you can recycle some of that tissue and you do a reverse, and you can even use that excess tissue to auto-enhance the breast. So this was actually this woman that I did back in 2004, and then 10 years later, she had some aging and everything, and so we were able to utilize this tissue, put it up, and tighten the abdomen by pulling it upward, and then I fixed my mons finally on her at the same time. But you can see we were able to, it does cost you a little bit of the scar that goes across the décolleté, but it was able to give me some tightening because we wouldn't have been able to get that out without really a vertical component. But this allowed the elimination of the vertical scar, but allow us to reshape the breast. So that's like I said, about 2 or 3 a year I do that. Medial thigh plasties, they're done very similar to a brachioplasty in terms of the technique. We equilibrate fat, we then tailor tack it, mark the pattern, remove the skin, and we often, there are techniques of just taking out a little ellipse here. No way does that fix the horizontal excess that almost everybody has in the post-bariatric thigh. So it is a vertical scar, and it runs pretty well. But there are a fair number of people that we can actually cut it off about here, so they can still wear a lower skirt and not show it too much. But also in its orientation, just like the arm, most people can't see it from the front or the back. It's only if you kind of have your leg outward. And then this was a young lady, late 40s, but she had a lot of deflation of when you lose a lot of weight, you lose it in the face as well. And there are very discrete fat pads in the face that give us the youthful look. And if you lose that volume, then it begins to give you an aged look. She wanted her neck improved at the same time, so we did a combination of fat grafting as well of the mid-face area, and then a lower face neck lift. And you can see I gave her a jaw definition. Scars generally do very well. Gave her a little more cheek lift. And it's a natural look. Another one. So That's a little bit of a gamut of what post-bariatric body contouring could look like.